Hi, Dr. Ann Conn today with another episode of the Conn Job. Today I'm delighted to have Dr. Wendy Lau as a guest. Wendy was born in Hong Kong. She went to boarding school in America and then received a computer science degree from Yale. Decided she wanted to work more intimately with people and went on to attend medical school at Cornell. She then trained in emergency medicine, and she's board certified in emergency medicine and addiction medicine. After an experience with burnout, she decided to leave traditional clinical practice. She went to Upaya, a Zen institute, and is now a Zen priestess. She works with healthcare providers, trying to create resilience. She wrote this beautiful book called The Inner Practice of Medicine that I read and enjoyed so much. It was very important and healing for me at the time that I read it. I recommend it highly, and I continue to draw on the principles from that book. So today I'm just looking so forward to talking with Dr. Wendy Lau. Thank you. All right. Good morning, Dr. Wendy Lau. Wendy, thank you for joining me today. We were recently together at a retreat, and I think I first found out about you when I read your book, The Inner Practice of Medicine, which I'd like to talk about today. But I would like to start with, can you tell me about the decision and how it unfolded for you when you left the practice of emergency medicine and moved to Upaya and ultimately became a Zen priestess?
Thank you so much, Anne, and so thank you for having me here. And it was really wonderful to meet you in person, just very recently. Um, and yeah, that decision was not, a pre-planned decision. I got into medicine like many of us did, in order to heal and serve people. But it got to a point, maybe a few years after training, like 5 years out or so, it got to a point where I was no longer feeling like I was effectively healing. I was doing everything technically correctly. I was trained well. I was, doing emergency medicine in New York. But I felt like my inner landscape was impatient, and it was getting more and more unempathetic or compassionate, that I wasn't doing what I was really practicing in my meditation practice. I've had a meditation practice since medical school. I had an inkling that I would need it for medicine, and I started just exploring and then kind of got myself into a regular meditation practice and yoga practice and all of that with a teacher. And we talk about being kind to people, being compassionate, and being able to heal from that kind of place. But I wasn't feeling it when I was at work, and I felt kind of like an imposter. And it came to a point where I got so burnt out in emergency medicine that I wasn't sure how I could do another 30 year of it. I was looking down, my career path, and saw this long road that I wasn't sure if I'm going to be able to travel down. So I took a little time off. I took some time to get stronger in my meditation practice. And during that time, I found Roshi Joan Halifax, Upaya Zen Center, where we have these clinical programs for clinicians. And I think Anne is going to come explore this with us soon. There's a program called Being with Dying for clinicians. Half are physicians, half are nurses, and it's specifically designed for these are clinicians who don't have this kind of training to look at our own how we look at our own mortality and how we hold our own vulnerabilities. And talk about moral injury. We talked about, how to be more present in our clinical practice, and all of it together in this beautiful community of clinicians. So I came to experience that in 2016, just, as a participant. And I also took the GRACE training, which is the compassion training that was developed for clinicians. I talked to Roshi and started going on the Nomads Clinic, which is a pilgrimage and a medical service trip to very, very remote areas of Nepal. And that is also life-changing. So that year, I kind of experienced the full gamut of Upaya clinician offerings, and just felt suddenly that something clicked. That somehow I wasn't able to connect my spiritual practice with my clinical practice, and those programs and being in Nepal and being with this beautiful community helped me connect them. And so I went back to work for a few more years with this in mind, and also starting to bring this kind of work out to clinicians as well. I started doing, grand rounds and also meditation teaching with physicians, mostly emergency physicians. And then I just decided I wanted to take some time off again to get deeper. And this was right before the pandemic. And so I took some time off, and then all of a sudden the pandemic happened, and I found myself at Upaya. And I had a choice to either go back to work or get deeper in this kind of service, which I found was very fulfilling, because my initial intention was just to serve and heal. And I feel like this teaching this way was able to help to heal the healers, basically. So I ended up writing this book, Inner Practice of Medicine, to combine everything I learned and my own and also in my own clinical practice, and be able to speak in the voice of the physician. As physicians usually don't want to listen to other voices as much, and we trust, our colleagues a lot more. So I wanted to write a book that speaks directly to our colleagues, and talk about these kind of difficult topics that we don't usually talk about. And I feel like this is kind of like the missing curriculum in medical education, that this kind of, inner practice is so needed if we want to continue practicing in clinical practice, especially in a broken system, to help us continue to be able to serve. And my wish is to bring this to younger people as well, to our residents and med students, so that they can start off their career with this kind of learning and this kind of experiential knowledge of our own, our own bodies, our own experience within ourselves, rather than trying to ignore, when we're starting to get burnt out or starting to, be too tired. Be more present for ourselves so that we can serve in a better way.
Well, thank you for that description. And for me, your book succeeded. Okay, when I read the book, it was the perfect medicine, so to speak, for how I was feeling. And it just gave me, I was able to draw into myself to handle some of the things that are difficult in practice in medicine in today's current corporate environment. And I guess I want to circle back to the 1990s, when I was in medical school. I can literally remember people would say, "Oh, you can't get attached to your patients."
Yeah.
And I knew that was wrong, okay? I had come to medical school a little later, like you had, after another career in chemical engineering. I think for you it was computer science, so these technical fields. I think we shared wanting to be closer with people. And I too developed a meditation practice in my 20s that has been sustaining for me. But anyway, I was being told, don't get attached to your patients, and the hierarchy in medicine training, I didn't feel like I could say that's wrong. I just kept my mouth quiet, but I was like, no, this isn't right. And then I remember when I actually got to clinical care, a lot of the physicians would say, that patient died on me. That was a common thing. And patients don't die on us. They die because that's what is going to unfold at that moment. And so for me, the way I can remember early on, I did neurology, and there's so many deaths. And when I was like in my very first beginning of it, somebody would come in and have a small stroke because their heart wasn't beating normally. And at that time it was Coumadin. They'd come to clinic and I would be like, oh, okay, take the Coumadin, you won't have another stroke. And then I would be in the hospital 2 weeks later and the person would come in and die and they hadn't taken their Coumadin. And I really thought, I'm not gonna be able to do this. I just thought, I don't know if I can tolerate this. And there were multiple situations like that. But then finally I came to realize, I'm like, my job is to offer the treatment and explain the treatment and offer compassion. It's actually their job to decide whether to do it or not. Like, it was over personalizing it. You know what I mean? We only have so much, people's lives are complicated in ways we don't understand. We can't understand because every life is so unique. But that was like a crisis point for me, where I needed to accept my limitations or I wasn't going to be able to continue. And fortunately, I was able to. But my hope, I'm so grateful for you and what you're trying to do, and I'd like to be a part of it too, because we can teach people better and give them tools to thrive in what we face. And we were just kind of blowing in the wind back then, and there was no guidance. The guidance I had was from like my own spiritual teaching and stuff, and we didn't even really talk to each other after all these terrible deaths. So I'm glad things are changing, and your book is so valuable, and I just honor you and thank you for writing it. Yeah.
Thank you so much. Thank you so much. That's exactly it. I think in medical education, we're not even explicitly and also implicitly taught to kind of stuff our humanity, to become inhuman basically in order to deal with these things. Yes, maybe there's a way that we can be to not attach too much, but also we need to acknowledge our very human reactions to facing suffering. This is our job. Our job is to face suffering. We watch people in pain. We, also have to inflict pain sometimes in order to heal. And so all of these things can kind of burden us and weigh us down if we don't know how to release them and don't know how to know where our limit is. And you had said, knowing our limit. And I find that, being able to be in touch with ourselves is so important. That's why I called the book Inner Practice of Medicine, is so that we can actually learn how to get in touch with what it is that we're feeling. And I always like to read this quote from Cinda Rushton, who is a nurse ethicist. She's the Bunting Chair of Ethics at Johns Hopkins University. And she wrote this book called Moral Resilience. And she talks about this term called self-stewardship, which we like to teach a lot in our courses because it distinguishes this sense of, or what people call self-help or self-care from what we're actually talk about as inner practice. Because self-care sounds like it's something that we have to do to make ourselves be okay, like this kind of outer thing, or like people say maybe you should just go do some yoga. That's like another thing to do in someone's like busy life. Maybe that is right for you, but seeing it as like an external something added is not what we're talking about. So here's the definition that she gives that I find so just helps me look at how I make decisions for myself and how I know what my limit is. So she says, self-stewardship embodies a commitment to know oneself, to responsibly and mindfully manage one's personal resources, to recognize and compassionately respect one's limitations, and to choose actions that are wholesome and life-affirming.
How beautiful. I mean, when I hear that, what comes up for me is, I think in medical training, we're just expected to go beyond our limitations.
Yeah.
And I know when I did finish training, it was really like a few years. I was kind of in recovery from, like, I needed to reel in and set reasonable boundaries, and it was just a constant expectation that I would have no limits and take care of absolutely everything, and it was a huge adjustment.
Yeah.
And I would say it's probably a lifelong adjustment, because then it becomes, that was just massive, but then it's on a continuum, I find, more subtly. But it is inhumane the way we train, because you're expected not to respect your bodily limits, need for sleep, food, restroom, all that. Yeah.
Yeah, it kind of trains us out of being an embodied human being. So we're told to not eat, not go to the bathroom when we need to not respond to our need for sleep or rest. And over time, it teaches us to cut us off from our bodies. And interestingly, we teach this a lot in our clinician programs too. And we've actually brought in embodiment as we go along in the training to retrain ourselves, because the way that we can allow for compassion to arise and to be empathetic to someone else is to actually feel through our bodies. So if we are cut off from how we ourselves feel, we have no idea what other people are feeling. So in order for us to even be connected with our work, be resourced by feeling into our compassion, we have to be back in touch and reawaken this sense of being connected. So in our courses, we always have, say, Being with Dying, that you're going to come to, Mary Taylor, who is a beautiful, wonderful embodied teacher of yoga, always guides these body exercises in between each thing that we, each session of talking. So we're not just up here like we always are in our heads, right, but we actually engage the full body in order to learn.
Right, that is so important, to listen to the body, because I think, in my experience, recognizing what's going on in my body can help me see what's going on in other people's bodies.
Yeah.
Especially because, as a pain doctor, interventional pain, I mean, sometimes I can just, before they even talk, or while talking, I can see this tension, the posture, the facial expression, the hand movements, all these things are being communicated. And it's very valuable, deep communication that can be transmitted through that. Sometimes I can feel into that when I'm calm and centered, and I had enough to eat and enough sleep the night before, and I'm not sick. Then I'm more available for that, right, which is nice, which I appreciate.
Yeah. And one of the things that we teach a lot also is that in the GRACE training, which is a compassion training, compassion is not what we were taught in medical school, where it's a script, where we're like, this is how you act like a compassionate person. Compassion is actually beneficial, not just to the person who is receiving it, but also to the person who is giving it, and also to the person who is witnessing it as well. And when we can feel into that compassion for someone as we're working, it actually resources us because it connects us back to our intention to serve. It gives us meaning to our work rather than doing everything mechanically. We can feel into our own intention and remember that we went into this difficult, career, not just not just to do the things mechanically, but actually to serve and heal. And that gives us a resource that is deep, especially when things are difficult.
Right. So I get the Dalai Lama, I believe, says compassion is the radical act of these times, and that kind of wisdom. For me, I agree with you. I mean, compassion is different than empathy.
Yeah.
And that's, I think Roshi Joan talks about Matthew Ricard's work, which had a lot of meaning to me also, because empathy is feeling with, intimacy, and compassion is this intention to act and to relieve suffering, and it's ever renewable. It's invigorating. When I'm in over-identification, that's exhausting.
Yeah.
Okay, that's and that I found that to be true not only in my work but in my personal life.
Yeah.
So these are very deep, beautiful teachings, and it's truly a spiritual practice. Practice needs to be worked on, practiced.
Well,
Yeah.
I mean, we teach that actually compassion, even though it's the feeling of when compassion arises is a spontaneous thing. But what generates compassion is actually trainable. It's not something that's when I was in medical school, I thought that either you have it or you don't have it. There's some nice people and then there's some not so nice people. That's not how it works, actually. We can actually train for compassion to arise. So that's what the grace training is for. The grace is an acronym. So GRACE. This is something that Roshi Joan had developed over the years for clinicians at first, and then now we actually train lawyers, we train teachers, we train social workers, and in Japan there's actually a grace society, and we go over to teach there, and they have a whole team that teaches it to doctors and nurses. So I'll give you a quick overview of what grace means. So the G of grace stands for gathering attention. So you can imagine if you're distracted or just divided or dispersed, the 3Ds. If you're, say, for me in the ER, if I am thinking about the next patient or what I have to do next, and then I walk into this patient's room, there's no way compassion can arise because I'm not even there. I'm not even present. So the G of grace is gathering our attention, and we teach techniques like breathing in and dropping our attention down and feeling the sensation of our feet on the ground so that we're totally here before we walk in the room. And then letting ourselves be undistracted. That's the G of grace. The R of grace is recalling our intention. That's what we were just talking about, our deep intention to serve, or I'm here to serve this patient. So if I walk into a room and already I am impatient and wanting to get to the next thing, or that I'm, I know that there's the ER is really busy, and I think that I'm there to just, get rid of this patient or trying to get out of there, then there's no way compassion can arise either. So the R of grace is an invitation to recall that I'm here to serve this person. Right now it's just about this person, and that I'm not here just to get this done, but to be able to heal and see what they need and be able to speak in the way that they need me to, and to see the big picture of what they need. That's my intention. So I take a breath, recall my intention, feel it in my body, and remind myself. That's the R of grace. The A of grace is attune. But first, we attune to ourselves first. This is what we were just talking about embodiment as well. So we attune to ourselves. Oh, I actually need to go to the bathroom first before I see this patient. Or that I'm hungry, I need to get a bite. Or that I'm holding on to some anger that I had because I was just talking to someone and they were like all riled up and I'm in this state of kind of arousal. So I attune to myself. I recognize that I'm holding this and see if we can go back to okay, now I'm here to just serve this patient. I'll let go of this from before and just be here. And then I attune to the other person, the patient, as I walk into the room. Now I'm ready to attune to them because now I have cleared what I'm holding or my biases that I might be holding. And so that's the A of grace, attuning to self and then other. And then the C of grace is considering what will serve. Considering in a way that is about not bringing in our own preconception of what should be done. And it's not just about diagnosis and treatment. It's not just about our clinical part of it. And that is part of it, of course. We're not letting go of our expertise about that. But we're coming in fresh also, without biases, without our preconceived notion. So we consider the big picture. So maybe you walk in the room and you notice that there's a family member there who is kind of nervous or is uncomfortable. Oh, maybe you consider that person, you need to address that person as well. Have them sit down. Or you notice that the patient is, just in pain and they're not able to listen to you, or they're distracted about something else. Maybe address that first. Then you can tell them what is needed to be done. So seeing the big picture, considering what will serve, bigger than just the clinical part of it. How we might talk to the patient, maybe we need to use a different tone. Maybe we need to sit down. Maybe we need to, rearrange something. So, or bring someone else in. So that's C of grace. And then the E of grace is to engage in that compassionate action. And then after we do that, ending. Ending meaning we acknowledge what we've done, acknowledge this moment that we've had with the patient, and also acknowledge what's not done. Sometimes there's stuff that can't be done, like you said, in our system. Sometimes, there's maybe I discharge this patient in the ER, knowing that they might not be able to actually follow up the way that I'm telling them to. Maybe they can, maybe they cannot. Yeah. And then I'm holding on to this kind of residual feeling of dissatisfaction or shame or guilt. Acknowledging that, being able to let that go, knowing that I've done the best I can in the circumstance that's given to me, and then be able to move on and see, to the next thing without holding on to this residual guilt and shame. So that's GRACE, and we train that in a weekend training, like a 3-day training. And then we do exercises for each of these. But then once you've actually gotten this down, it can be done within 3 breaths. As you're walking to see your patient, you're grounding yourself, you're recalling your intention, you're attuned to how you're doing, and then you walk in the room, you're attuned. And then all of this can be done in situ without, too much time. So it's a very practical way of, so that we can arouse this kind of compassionate action and set the field so that it can happen.
Yeah, that's just a beautiful psychological arc to go through to be fully present. I mean, deep knowledge has gone into that, and I value it. And yeah, I honor that and want to do it. I think in my experience, it's more difficult than ever. I've been practicing for 25 years, and so I've seen the transformation of our system. Yeah. And having also gone to Asia and been in the hospitals and see what it's like when a medical system is not commercialized and how different that is. Because now, as medicine is becoming more corporate, and these corporations have a fiduciary obligation to make money, and we as physicians, we're committed to the patient and to public health, and sometimes those things feel such at odds. It's painful. I feel it as painful. And before we got on, I was sharing a story from this week that I with a patient, and the thing about this story is it's actually not that unique. So just to give a succinct version of what happened, is one of my longtime patients came to me, and what we've noticed is deductibles for insurance have gone higher and higher, and many people have a $7,000 deductible now. So the patient comes to me, and when I walk in the room, I'm like, oh, she looks pale. That's the first thing I noticed before I talked. And then she started coughing before she or I talked. And I'm like, oh, what's happening here? And so, I asked her what had been going on. And she said, oh, well, I've had the flu. I got the flu. And so, I'm just like, so what happened? How were you diagnosed? And she told me she was taking care of her grandson who had the flu. He went to the pediatrician, and a few days later she got sick. And she explained to me that she didn't go to the doctor because she couldn't afford it. And she knew there were flu medicines, but she thought they were really expensive, and she was going to have to pay all that cash, so she didn't go. And then she proceeded to tell me that like a week later, she actually got shingles on her face, which is so deeply painful. And again, she didn't go to the doctor for the same reasons. And she also had a misunderstanding that the shingles medicines are really expensive, but they're not. And I told her that, tried to reassure her if she had shingles that the medicines aren't expensive. And then she proceeded to tell me that she couldn't continue with our treatment right now. Okay, so she has chronic neck pain, and I burn the nerves in her neck. It works really well, but she doesn't have the money for the copay, so she can't have the therapy right now. And I'm listening to all this, and I'm thinking, while I'm hearing her cough, that she could have pneumonia, because after flu, people and shingles, their immune system takes a dip for a short time, and they can get pneumonia. So I was discussing that possibility with her, but I was feeling so sad, and I was feeling helpless because this lady basically can't access what she needs because of her high deductible and her challenging financial situation. So that was an example. I mean, I was just with her, listening to her and expressing concern and my sadness for her, but that I had trouble shaking off because I just don't see an easy solution. I mean, I was with her, I offered my presence and what I could, but I felt sad about it. I think I still do feel sad about it, and some helplessness. So it's just challenging. Anyway, I was hoping for your feedback and your thoughts about the transformation of our system and the barriers. Anyway, I'd like to hear your reflections, please.
Well, I just want to hear how you work with that sadness and the feelings that are left over in your experience and in your spiritual practice.
Well, I do tell my nurse, I'm close to my nurses. Okay, so I share with my nurses, and that does help. Okay, first of all, they need to know what's happening so you tactically try to take care of her, okay, and get plans and help, like we know her financial situation. So sharing with my nurses, because it helps me not carry it alone, and it helps us plan and know what the patients are going through. Okay, so I mean, my meditation practice has been transformative for me. It helps ground me. I'm working within a system that, again, I mean, my power is limited. Okay, I can offer her love and compassion. I feel like my job more and more is to help people navigate our system. Okay, I give them, which is of course tactical, But, I just try to honor and do, it's like self-havening, some people call it. Like I go to my office, I talk to my nurse, then after she leaves, I just try to take deep breaths, okay, and do like, being with it, just trying to be with it. The feelings of what has happened and let them run their course. Because when I've noticed if I try to deny and pretend, it doesn't work that well. So those are some of the tactics that I'm trying to use to handle things like this, which seems to happen more and more.
I mean, it's so difficult because our system is broken. And we are, our values of service is being opposed by the values of capitalism in our system. And, the biggest, I don't know how to fix the system, and I don't have an answer for that. I wish I do. But in order for us to continue to work in this system, we have to recognize how the system is affecting us. And like you said, letting the feelings go through without trying to suppress them is important. And what you said about your nurses is super important. That's having a community to be able to talk this through. And, we have been doing a physician retreat here based on the book. And it was, the first two were so healing for me personally, because we had 30 physicians in the room from different specialties and different stages of practice and different places, working in different places, but all having the same, medical training from medical school with the same kind of language. But I realized at the first one that we've never, after medical school, none of us really talked to each other across specialties. And it was so refreshing to have everybody in the same room, with the same language, but have different kind of experiences. And then it was just so healing. Everybody has so much wisdom, and we were able to share our own experience and have that be reflected in each other. And having all that different experience in our own specialty that are so different, but yet so the same. Isn't that funny? I just realized I never talked to anybody outside of my specialty, other than, in emergency medicine we do, but we talk to other specialties, but they're never, fun conversations. We're always giving other people things to do. So it was super refreshing. Yeah.
So it brings up a story. You're right, we don't talk across specialties a lot, but something spontaneous happened. It was so unusual during the pandemic. Okay, and my colleagues, we trained during the HIV pandemic, basically. And so we were at this party for a colleague, and it was kind of in a break in the pandemic. And these are doctors in the community I don't know that well, like cardiology. I mean, I know them, but I don't spend a lot of time with them. And just spontaneously, all this pain started pouring out about the HIV epidemic. I mean, that's years ago. Okay, really, I mean, I felt tearful. It was just, I think, it was just stories about things that had happened, at Charity Hospital in New Orleans, the big public safety net hospital during the HIV epidemic. And I had been noticing that during the COVID pandemic, some of this stuff was just coming back to me spontaneously. And I really hadn't discussed it with anybody. And at that event, it was just a spontaneous outpouring. It was very interesting. And actually, I think it was healing. I mean, we were clearly carrying these memories. And what was so hard, it's young people dying in very difficult ways. And this is before HIV was like a treatable illness. Now we have long-term suppression. At that time, it was just coming out and most people weren't on it. So I agree that we don't talk enough, but there was just a spontaneous outburst of it was actually very loving at this party. And so I felt so happy that it happened and grateful. and it doesn't happen enough. And I do think it was driven by the pressure, the emotional pressure people felt in the COVID, during the COVID pandemic. Yeah.
Yeah, and so I think it's our job to create more of these kind of spaces where we can come together and talk. And, a lot of the problems that we have in the medical system, stems from us, not talking to each other. And, and there's like, a loneliness pandemic or epidemic anyway in this country. But I think, people who are in professions that are kind of like medicine or law, people who have a lot of education, who are taught that we are supposed to be experts in our field, have actually even more of that kind of loneliness epidemic. So we need to create more spaces where we can talk together. Yeah.
Right. So being an expert doesn't make us less human. Being an expert's fine, it's a beautiful thing. But I mean, all the humanity is still, with us. And that's a beautiful thing too. But I think sometimes we haven't acknowledged it enough and tended to it and loved it enough. Yeah. And I guess that makes me think of what happened in this retreat that we were both at when there was a medical emergency.
Yeah.
Yeah. So basically, at work, we kind of have on our persona, for better and worse, okay, about what's, and so on a retreat like this, it just was meditation and, a great community. And so we would go down to see sunset at the beach by our retreat center. And so a lot of us would go down, so beautiful every evening. And so one evening, like the third day in, maybe I was walking down and I saw a lady laying on her side next to the water, and somebody was starting chest compressions on her, this male nurse. And so, I went to her side, and so did another doctor and other people. And she had what we call a pulseless cardiac arrest, and then she had gone into the water and, of course, inhaled some water. And she had no breathing and no pulse. And, the ER nurse really had great skill. He clearly knew how to do chest compressions really well. And I was so grateful. So if we were clearing her mouth and doing the things, it was a long code, really long, probably 7 minutes total, which is forever. It feels like forever. She did ultimately get her breathing and respiration back. And it really felt like a miracle because she completely recovered. She did not have a neurological injury, but it was pretty shocking that this happened. And then, we got you involved, and I don't know, would you like to tell what it was like for you?
Yeah, sure. I mean, I wasn't there on scene at the time on the beach. I only heard about it afterwards at dinner. And, I went to check on the person who had that episode, and she was taken to, a local clinic and made sure that she was okay and that she was getting transferred to a bigger hospital to get checked out. And then, once I saw that she was fine, what I was most worried about was our ER nurse who was there on scene, who performed the resuscitation. Because I had known that this person had had to take some time off of work because of the trauma that they had felt at work, and had some kind of PTSD. And, I've seen that a lot in my career as well, of, people needing to take time because of, traumatic situations that they've experienced at work. And then coming to this retreat and having to do a resuscitation on the beach out of hospital was, I thought, probably a bit traumatizing. So my primary concern was about that person, that nurse. So I later, found them and just wanted to see if they wanted to debrief and talk about it. and they were fine and okay. But it's hard for us when we're out of hospital, because in the hospital we have a whole team, we have everything we need, we know it's going to be okay no matter what, even if because we have people to help us. And also we are protected by our identity as a nurse or a doctor, that we can kind of be protected behind this kind of shield of identity.
Mm-hmm.
But when you're on the beach while you're trying to relax, that's not there. So I wanted to check on him and make sure that everything was okay. But he was okay. But we wanted to make sure that he had a space to debrief, and it was so beautiful. All the clinicians got gathered in the cafe, and we all
Yeah.
talked and ate snacks, and it was it felt like a time of just again, kind of like what you experienced, with all the physicians there, being able to talk about to debrief and talk about how we normally don't debrief, and
Yeah.
how we can do better. We can do better.
Yeah.
Yeah.
Yeah. I did. It was nice because we did all gather together and support each other.
Hmm.
And it was in a relaxed way that we usually don't have time to do at work.
Yeah.
And I appreciated that. And people shared their other experiences.
Hmm.
The ER nurse shared experiences that brought this person to the place of having PTSD. And I mean, yeah, I noticed for me it brought up old codes that I've been involved in. And I mean, and during this code, I was just clearing the patient's mouth and checking their pulse, just like playing a supporting role. He was really running it. But it was nice that we could come together, and then we were able to like check in over the next few days in this calmer environment. So that was nice. And she did well. Of
Yeah.
course, that felt like such a relief, such deep thanks. And her sister came back and talked to us at all. So we got the entire arc that we don't get a lot of. So this happened. Then we all got to talk, and then we actually got almost like resolution, and that she kept, the sister came back, and so it felt really nice. I don't know if I would call it complete, but it felt really nice, and restorative, and so I felt so grateful.
Yeah.
Hmm.
Yeah.
Yeah.
Yeah, that's like what we talked about in Grace, the ending. Ending is important. And of course, sometimes we can't get the actual ending to be nice. This time it was, luckily, very fortunately, she was fine. But even when things don't go well, how do we come back and understand that we've done the best we can, and not hold on to that guilt and shame if things are
Yeah.
not exactly perfect? This really went very well, but how do we hold ourselves? How do
Yeah.
we debrief with others? How do we um, end in a way that we don't carry this story with us in a way that burdens us? So those are things that we like to talk about in our compassion training as well, because it's not just about showing compassion, but it's also about this compassion that includes ourselves, that we can see that we are we are doing the best we can in an imperfect kind of situation.
Yeah, that's, I mean, very valuable to think about because, I mean, we can apply our skills perfectly and
Yeah.
beautifully with well-developed skills, and difficult outcomes can unfold.
Yeah.
That happens. So I think when I was younger and I wasn't confident in my skills, it was even more difficult because then I was questioning myself. Now I mainly feel confident in my skills,
Yeah.
so that part's easier. But again, it's just situations have a lot of complexity, and
Yeah.
I'm appearing in a person's life at a moment, and my job is, I try to think of it like I apply my skills, I send love and good intentions, and some of it's out of my hands, and that it helps me be calmer when I'm confident in my skills.
Yeah.
Okay, but it's not easy. Yeah, what are your thoughts on that?
Well, but we're actually also talking about the system, not letting us do our job in a way that we want to.
Yeah,
For example, not being able to spend as much time as we need to with a person. And that, can cause moral injury over the long term. And that's that kind of tension between what we know is the best thing that we can do and what we actually can do is what causes that kind of moral injury and can over the long term burden us and cause burnout. And the worse the system gets, the more this can happen. So we need to recognize this tension
yeah,
and know that this is, there's some things that are not ours to fix, as not ours to hold. And we do the best we can in the circumstance that's given to us and know how to let go of what's not ours. And that's very important.
it's important, and I mean, everybody does this their own way. For me, I take off and I go to things like the retreat. Years ago, I wouldn't take off as much, and now I know that I need to take off so that I can continue to do it. If
Yeah.
I didn't take off and go to meditation retreats and go on vacations, it helps me recover. That's one of the many tools that I use,
Yeah.
and but there's no way to tie a bow around it. I wish I knew how to fix our medical system
Yeah.
also, and I don't. I do have, I mean, we can rely on change. That's one thing we can rely on, and that is an avenue for hope, like Rebecca Solnit says. And so it will be evolving and changing, and that is opportunity, that good things will come forth. So that is possible. We just have to see
Yeah.
what happens. Yeah.
Yeah, that's why I love that definition of self-stewardship. And it says that we recognize and compassionately respect one's limitations and to choose actions that are wholesome and life-affirming. Sometimes that action can be we need to take time off. We need to step away. We need to reduce our hours. That can be what is needed. So we have to see what is actually right for us.
Right, introspection, yeah. So what have we not talked about, or what have you not said that you'd like to add as we come to the end?
Yeah, I just want to thank you for doing this work because that's what we're talking about. Having these kind of avenues of being able to be together in conversation about difficult topics that we face every day. And so, all of us together, with my work, with your work, maybe we can, bring more people in to have these kind of conversations so that we can be able to serve better, but also bring in systemic change.
Right, so we need a network of people talking about these things because,
Yeah.
Boundaries, we're taught to do boundaries, that's fine, and that's really important, but there's a systemic problem that needs to be moved so that flourishing can happen for patients, doctors, nurses, everybody in the medical field. And of course, all that, that just propagates through families and society, that we know. So yeah, I just try to keep our voices going to facilitate love, connection, compassion, and positive, skillful movement around these issues.
Yeah. Thank you so much. Thank you for
Thank you.
having me, and thank you
Thank you.
for the work you're doing. Thank you.
Thank you so much.